Okay. Yeah. We shall be starting in a short while. I can see a great number of participants. In a few minutes, we shall be starting. I wish to welcome all of us, and I trust that we are going to have a good session of knowledge sharing, learning from one another, and encouraging one another in the profession. Sorry, I realized I was not being heard. Good evening once again, and good morning, depending on where you are. My name is Dr. Pamela Haiduru. I'm welcoming all of us participants from across the globe. I want to recognize that we have 33 countries that have registered for this webinar, and drawing participants well over 300. And I am hoping all of us shall be on board so that we can be able to take this opportunity to learn together. I want to appreciate ISSUP Global for the support to ISSUP Kenya in preparing for this webinar. Our topic of discussion this evening is we really want to address the unprecedented challenges in management of substance use disorders and gender-based violence in the midst of COVID-19. We know that we are in a new dispensation. COVID-19 is a great challenge in the world today. And as it has caused us to have a new way approach to things, a new way of approach to learning and interacting. And this is one of those things that we are going to do this evening. I want to introduce our presenters. we are privileged to have presentations from one of our own, Dr. Richard Gakunju. Dr. Gakunju owns a master's in clinical pharmacy and public health. Dr. Gakunju is a certified addiction professional. Who owns actually ICAP 3. He is the clinical director of Movement Against Substance Abuse in Africa. He is a certified global master trainer in the UPC and UTC and serves as the trustee for ISSUP Kenya. Dr. Gakunju is the chairperson of the Global Center for Credentialing and Certification for Addiction Professionals, and also a member of the Pharmaceutical Society of Kenya and the Pharmacological Society of Kenya. Also, we shall be having a co-presenter, Jacqueline Anundo. And Jacqueline Anundo, also from Kenya, is a registered clinical psychologist with well over 10 years of experience in mental health, treatment, training, and research. She is the clinical director of Kisiwa Wellness and Psychological Support Services, and a lecturer and guest lecturer in Ekima University College. And Jackie is also the Honorable Secretary of ISSUP Kenya and currently undertaking a PhD in clinical psychology. So this evening, we are privileged to have very well-versed presenters in the field of mental health. And allow me, without taking a lot of our time, to invite Jacqueline Anundo to make a presentation. Welcome.
Thank you very much, Dr. Pamela, for that wonderful introduction. So good morning, good afternoon, good evening to all participants from where you're listening from. Indeed, it's a pleasure to be able to take you through this presentation. And I believe that we are going to interact and learn more about COVID, about GBV, and also about SUDs. As you all know, learning never stops. So without further ado, I'd like to jump in straight to my presentation. So this presentation, basically, we want to be able to fulfill two objectives. We want to be able to understand to create an understanding of the new risk factors for GBV amidst COVID, and we also want to help professionals who are on this call to be able to explore and develop new strategies in management of GBV amidst COVID-19. So before I go into my presentation, I'd just like to take you down memory lane, what used to happen pre-COVID. There was a lot of display of affection, hugging, shaking hands, among other forms of affection. Working persons were busy due to engagements. There was a lot of family vacations and outings. There was economic stability. There was availability of resources. And in our society, there was less exposure to online world, particularly for our children. Online classes were not there, they were going to class physically. And then there were large social gatherings, whether it was a happy occasion or a sad occasion, a party, a birthday, a wedding, or whether it was a funeral, the gatherings were large. And of course, we were not wearing masks. So what happened during COVID is that, on a positive note, is that more family time, there was more family time because most people are now working from home and are still working from home. However, COVID brought with it also a lot of challenges, pay cuts and job loss. So there has been a lot of economic strain. As a result, there's been increased substance use. Mental health issues have also been reported to have increased, particularly depression and anxiety. There's also the element of gadget frenzy, where we all had to rush out and buy gadgets because we have to attend online meetings, we have to do presentations online, our children have to learn online. So there was a lot of gadget frenzy. And then virtual meetings fatigue. From one virtual meeting to another and another and another. By the end of the day, you are extremely exhausted. And if this is your daily routine, you find that you become more fatigued as opposed to even actually attending physical meetings. And then there have been increased cases of GBV. And that is my topic for this day or this evening. What do we mean by gender-based violence? Gender-based violence means that it refers to harmful acts that are directed at an individual based on their gender, and it is deeply rooted in either gender inequality, the abuse of power, or even harmful norms. Gender-based violence comes in different forms. So when you're talking about gender-based violence, you need to understand, are you talking about intimate partner violence, or are you talking about domestic violence? So when you're talking about intimate partner violence, and which is and this is actually a common form of GBV, it includes physical, sexual, emotional abuse, and even controlling behaviors by a current or former intimate partner or even spouse. And this can occur between heterosexual or even same-sex couples. When you talk about domestic violence, it refers to violence which is carried out by partners or family members. And this violence is not a preserve for the female gender only or the male gender. Either gender can experience this violence. Now, when you talk about abuse, there are various types of abuse. So as professionals on this call, it's important to be able to understand in what way are you helping your client? What type of abuse is your client going through? If your client is going through physical violence, then it means that this is the kind of violence that occurs when a person uses a part of their body or an object, to harm the other person. Sexual violence is when a person forcefully, or unwillingly forces the other to take part in a sexual activity. Now, neglect is also a type of abuse. It occurs when someone has the responsibility to provide care or assistance for an individual, but does not do that. What about spiritual violence? This occurs when someone uses an individual's spiritual beliefs to manipulate them, to dominate them, or even to control them. And most of the times we find that people be manipulated and threatened, you'll go straight to hell, or something regarding their spiritual beliefs, so that they can be able to do what this perpetrator would want them to do. Psychological violence occurs when someone uses threats and causes fear in an individual to gain control. Emotional violence occurs when someone says or does something to make a person to either feel worthless or even stupid. Emotional violence has been equated to someone stabbing you with a knife, removing the knife and stabbing you again. Because when you think of the harsh words or the painful words that this person says to you, then it can pierce you the same way somebody can actually pierce you with a knife. Cultural violence occurs when an individual is harmed as a result of practices that are part of his or her culture, religion, or even tradition. We know in our African culture, we have a lot of cultural practices. So someone may use some of these practices as a way of harming you. Verbal abuse occurs when someone uses language, whether spoken or written, to cause harm to an individual. And then there's also financial abuse. And this occurs when someone controls an individual's financial resources without the person's consent, or even misuses those resources. Sometimes there could also be social online abuse, where we have cyberbullying and things like that. So it's important as a professional to be able to know you're helping your client, you're helping the patient to handle which type of abuse, because you cannot say that my client is going through abuse, so which specific abuse are you handling? Now, if you forget everything that I say in this webinar, please don't forget the cycle of abuse, because when you want to help someone who is going through any form of abuse, it's important to be able to understand the cycle, because if you teach this person the cycle, if psychoeducate them on the cycle, then it's now easy to be able to break the cycle. Now, the cycle starts with tension building. In this particular stage, a lot of tension is building up. It could be because of the daily pressures of life. It could be as a result of conflict over children, marital issues, the job loss that has come with COVID, the pay cuts that have come with COVID. So the abuser in this particular home, for example, will feel ignored, will feel threatened, will feel annoyed, will feel wronged. The survivor, on the other hand, may feel like they're walking on eggshells around this person. And when the tension becomes too much for this person to bear, they move to what we call the explosive phase. In the explosive phase, tension will be released in a variety of ways, depending on the history of violence in that kind of relationship. And typically this gets worse over time. The abuser is out of control, will terrorize the victim for hours, break things, hit the survivor, spit on this person, push, choke, burn, tie up, sometimes even ends up raping this person. So you find that in most cases, survivors of such kinds of violence, will at this stage experience have a lot of bruises and even broken bones, and may even end up in hospital. Sometimes also the police are involved in this stage. Then we move to the reconciliation stage. The abuser will feel remorseful, will apologize, and will beg this person to believe that the violence won't happen again. But even the kind of apology that this person gives is an apology to blame the victim. Don't be making me so mad. You see, if you make me mad, I end up hitting you, and I don't want to hit you. So that is the kind of apology that this person will always give. So it blames this person for the abuse, and most of the time, this person who was abused is still in shock of what happened, and it leaves them in a very vulnerable state. In most cases, they end up accepting these apologies and even accepting gifts that are offered by the abusers because of their vulnerability. So what we have here is a false resolution based on denial and minimizing of the abuse, and then life goes on. The abuser may even encourage this person to go shopping, oh honey, that car that you wanted, maybe you can go buy it. You said you wanted us to buy a house, we can go check out some houses. You wanted this dress, maybe you can go buy. So the abuser tends to entice this person with a lot of gifts. Then after the reconciliation stage, it moves to the honeymoon phase. In this particular phase, the abuser may show jealousy, which makes this person to feel special and important. They may say words like, I love you, that's why I do those things. And at this point, remember, this abuser is also showering this person with a lot of gifts, and therefore this makes the survivor to feel very important and to feel loved. However, this stage will not last long, because it will move again to tension, to explosive, to reconciliation, and back to honeymoon. So it will be a cycle that runs over and over and over again. As a professional, it's important to be able to understand this cycle so that you can help your clients, to help your patients to be able to break the cycle. Unless this cycle is well understood and broken, the cycle, the abuse might as well just continue. So how is GBV associated with COVID-19 pandemic? Before the pandemic, WHO gave a report that there were 243 million women and girls who were aged 15 to 49 who had experienced sexual or even physical violence. Now, since the pandemic, these numbers have increased, and this has been exacerbated by things like security issues, health concerns, money worries, as a result of maybe job loss, as a result of contracting corona. So it has exacerbated, these elements of violence. People are working from home. In Kenya, we had a lockdown in March, and therefore many people had to go back to their families, and some of the living conditions, you find that they live in a cramped kind of living condition. So you find that people would spend a lot of time with each other, and if there were issues that were coming up, tensions that were growing within the families, you find that living in such conditions also just exacerbated the problem. And sometimes because of the lockdown, you find that survivors were locked with abusers in the same house or in the same environment. So we find that during this period of isolation, many of them were forced to actually put up with the abusers, and this abuse continued. And then because of the restrictions of movement, we find that this also exacerbated this because people were frustrated, people were angry, people were afraid, there was a lot of fear, and because some people don't know how to deal with their problems, they end up taking it out on others, taking out the frustrations on others. Then deserted public spaces, even those who had the liberty to move from one place to another. All the public spaces, were like ghost towns. There were no people, and this ended up just frustrating individuals even more. In Kenya, during that period of lockdown, a month later, our Chief Justice, David Maraga, gave a report in which he said that sexual offences constituted to about 38.5% of the cases that were recorded. Maybe this number would have gone up if all the cases were recorded, but these are just recorded cases. And this was just between the time we had the lockdown and April, and that is just a month away. He also went further to state that in January, there were 50 cases that were recorded. In February, there were 62 cases. But then in March, during that lockdown, the cases went up to 106. So you can see the way COVID itself escalated the cases of gender-based violence. Our Ministry of Public Service, Youth and Gender Affairs also went ahead to do their own survey, and they came up with a report a few days after the report that we got from the Chief Justice. The report came on 10th, and it stated that there was an increase in the past 1 month of gender-based violence of up to 42%. And these are very high numbers. Now, these increase in gender-based violence are not just limited to Kenya only. Worldwide, there were also various reports of increased cases of gender-based violence. According to a UN report in 2020, it stated that gender-based violence cases increased from 20% all the way to 90%. And as you can see, China had the highest, and that is 90%. Now, a case in point is New Zealand, for example. Just on Good Friday weekend alone, there was a spike of 20%. In Denmark, the government reported that there was a rise in men who had become homeless because of conflicts in relationships during this COVID period. So this is something that has touched the entire world, and it is not just a preserve of certain parts of the world alone. And why is this? This is because COVID did not choose a particular country. COVID is worldwide, and everybody had to experience it, and people, experience it in different ways. Some of the causes of gender-based violence, the obvious reason that I've just said is COVID. Then gender equality issues also comes into play. Upbringing, how were you brought up? Were you brought up seeing your parents fighting? Were you brought up having experienced some of these forms of violence? Did you experience a particular type of abuse growing up? And did you get justice for it? So when you grow up, somebody imagines that this is how life is, or this is how problems are solved. Then survivors of abuse, according to research, have also been known to also extend the same to other people, and they have ended up becoming perpetrators of the violence that was meted on them. Cultural influences, substance abuse, religion has also been used, mental disorders. The people who, because of their mental disorders, probably someone is going through a psychotic episode. You may find that this person may not be aware of what they are doing, and they may end up harming other people. Low self-esteem has also been known to cause gender-based violence. Poor anger management skills, and people with poor anger management skills have a tendency to experience periodic or erratic anger outbursts, and you find that in the moment of these anger outbursts, they may actually become violent or aggressive towards other people. Differences in literacy levels have also been shown to cause gender-based violence. particularly where one partner is literate and the other partner is illiterate. Now, what are some of the thought patterns that goes through a perpetrator and even a survivor? What form of communication do these two people understand? For example, when a perpetrator communicates to the survivor and says that I hit you because I love you, to the survivor, this means that this is what love is. If he didn't love me, let me use a man in this example. If he didn't love me, then he wouldn't be hitting me. He wouldn't be doing this to me. So the effects on the survivor is that it brings a lot of confusion and re-victimization continues. Another communication is that the abuse is your fault. You know, you make me angry, that's why I hit you. The survivor will interpret this to mean that I am bad and I'm to blame. What this means to the survivor is that it brings again a lot of helplessness, self-blame, and even confusion. No one will love you like I do. So the survivor will interpret this to mean that I'm alone in this. And without this person, I can't make it. So the survivor becomes dependent and fearful of living. And then the perpetrator might communicate also that I'm doing this for your own good. You don't own your body, I do. So what does the survivor interpret this to mean? It means that other people know what is good for me and I have no control over what people do to me. So this one sets doubts in their judgment, poor boundaries, and again, re-victimization. Now, another communication is that no one will believe you if you tell. And most of the time you find that perpetrators are very nice. They have very good PR with people out there. And people out there see them as the most kind, the most generous, the most loving person. But when this person is alone with you, the behavior is different. And that's why the perpetrator believes that no one will believe you even if you tell. So the survivor interprets this to say that I'm alone and no one cares. For example, sometimes in our African setup, when you go back to your parents, they will always send you back, that you're supposed to go back to your husband and build your marriage. And what they will ask you is your husband paying school fees for the children? Then you say yes. Is your husband providing you with food? Then you say yes. So what is this that you're saying that you're being beaten? Even your mother was beaten, yeah, and she's still here. So why do you want to spoil your marriage? So go back and continue making your home. This thing will come to an end one day. So what happens? The survivor goes silent and doesn't seek help, and this kind of abuse just continues over and over and over. Now, what are some of the symptoms that you might see in children who have been exposed to violence? They could have sleeping and eating disorders. They would be experiencing nightmares, or they don't want you to turn the lights off. They don't want to go to sleep. Enuresis, a child who had stopped urinating on the bed may start urinating again. So this is a clear sign that something is wrong with this child. Speech disorders, you may find this child starting to stammer or to stutter, something that this has not been happening to this child before. This child could withdraw and isolate and doesn't want to associate with others. This child could even begin to develop deviant behaviors. They would start doing things that they were not doing before. At school, they would even take things that don't belong to them, basically steal things that don't belong to them, not because they are thieves, but they just want to attract attention to show you that there's a problem. Can you come and deal with this problem? Because most of the time you find that the perpetrator may have threatened this child. So this child is so fearful of coming out to say exactly what is happening. And for younger children who cannot be able to express themselves, you can be able to see it in their behaviors. A child could become aggressive, could become clingy. When you want to leave the house, the child is holding on to you. Don't go, mom, don't go, dad, don't go. Temper tantrums is another thing, or crying a lot. You'd find that infants tend to cry a lot. Yes, infants do cry, but when the crying is too much, then that's a red flag that something is not right. Depression, difficulties at school with poor academic performance. Then they could also have some suicidal ideations, or even they could also attempt suicide. So how do survivors present themselves clinically? They go through depression, so you'll see in them some depressive symptoms, anxiety symptoms, PTSD, and even sleep disorders. Suicidal thoughts or attempts, or even self-harm. They could also be self-medicating with alcohol or other substances. They could also be unexplained chronic gastrointestinal symptoms. There could also be unexplained reproductive symptoms like, pelvic pain. Sometimes when they go to hospital and investigations are done, you may find that nothing is found. Adverse reproductive outcomes could also occur. For example, multiple unintended pregnancies or even terminations. There could be delayed pregnancy care. This person who was raped may refuse to go for antenatal care. And you find that they may even refuse to see the doctor, whether before or even after the birth. Then there could also be adverse birth outcomes. There could be repeated bleeding from the genitalia, and even sexually transmitted infections will be detected, unexplained chronic pains and aches. And sometimes, because someone going through gender-based violence will not come to the hospital and present themselves like they're going through gender-based violence, so they will talk about different aches and pains. So in most cases, if you don't ask about the gender-based violence, you may find that you may diagnose, a somatization, because today the pain is on the head, tomorrow is at the back, the other day it was the stomach. So it's very easy to misdiagnose such people. Then there could be repeated health consultations with no clear symptoms. So they present very vague symptoms that you may not be able to tell exactly what is happening. Some of the behaviors consistent with the GBV survivors include injuries inconsistent with explanation of the cause. You see a black eye, a broken arm, and they tell you that I fell on the stairs, I hit the door, or I just slipped and fell. And sometimes when you ask, how did you fall? I fell on my back, but you can see the face is where the injuries are, or the front part of the body is where the injuries are. So it's not very consistent. Frequent appointments with vague symptoms. Sometimes they try to hide injuries or even minimize the extent. Oh no, this arm, yeah, I was just playing and something happened to the arm. It's not something serious, because they're trying to minimize the extent of what is happening to them. Sometimes you may also notice that this person is reluctant to speak in front of the partner or the accompanying adult, or they may appear even submissive or afraid in front of this person. So when you notice that the person who has accompanied the survivor is actually answering questions for this person and appears to be the one who wants to answer everything and appears to be the one who wants to dominate that entire session, or even taking history if it's at the hospital, then you should know that something is not right. There is also non-compliance with treatment, turning down help, they miss appointments, and they also have multiple injuries at different stages of healing. Last week they came with this particular kind of injury. It seems to be healing, but then another injury has occurred, and another at different stages. They're very fearful, they're overly anxious and depressed. And then sometimes you may find that the partner who has accompanied the survivor may refuse to even leave the room. So it's important to be able to find tactics find ways in which you can be able to be alone with the survivor so that you can be able to take your history. Sometimes also, the survivor may be admitted in hospital, but may request for early discharge, particularly when the perpetrator feels that the survivor may say something to the hospital staff that may incriminate him. He will insist that the patient be discharged. So why is it that survivors do not seek help? One, they feel ashamed, they feel guilty. They also choose to deal with it independently, or they feel that if they can only disclose it to one or two people close to them, and they also believe that no one can help them. Sometimes they minimize their situation. They believe that it's too minor to involve services. And then there's also the element of stigma. It can either be self-stigma or social stigma that may prevent this person from seeking help. Fear. Sometimes they may also be unaware that there are services that are actually available to help people who go through gender-based violence. So as a way of intervention, what can you do as a professional when you encounter either an adult or a child who has gone through gender-based violence? The first thing is to be able to assess for safety. Is this person safe? what are the immediate needs? You will not be able to take history from this person if you're dealing with someone who is hungry, someone who did not sleep, someone who first needs to feel comfortable, first needs to be reassured of safety. So you need to be able to take care of the immediate needs of this person so that you can be able to help. It's important to be a good listener. So listening skills is also very important. What the person is saying and how they are saying it is what you should be able to listen to. Listen to what is being said and also the nonverbal things that are being said. It's also important to normalize sharing of feelings and empathize with this person. When you normalize the sharing of feelings, this person will feel more comfortable in sharing what happened with you, as opposed to if you make it look like this is something that is extremely serious, it will continue to scare this person even more. Yes, it's a serious thing that has happened, but normalize the sharing of whatever has happened. Take note of nonverbal cues. Also take note of visible physical injuries, because these are things that you're going to put in your report. Take note of the partner or the relative who has accompanied the patient and seems to be answering questions for the patient. Sometimes you can even send this person, could you get your wife or whoever a glass of water? There's a water dispenser out there. In the few seconds that you have alone with this patient, you can be able just to get something out of this patient that may point to the direction of gender-based violence. Like if you notice visible injuries, then you can ask, did he or did she do this to you? Then the person will either nod or say yes. And by the time this person is coming back, the partner is coming back with a glass of water, at least you will know that whatever is happening to this person is as a result of violence, gender-based violence. So once your patient or client is comfortable in a private room, take history and do it at the patient's pace. Don't do it at your pace because you want to finish your shift or something. Remember, this person has lived with fear for a long time. They need time. At the same time as you're taking history, it's important to assess for the mental status of the patient. It's also important to, after that, to develop a treatment plan. And your treatment plan must be a multidisciplinary approach kind of treatment, because the patient may need a physician, may need maybe a nutritionist, may need a psychiatrist, may need a psychologist, may need other specialized care. So it's important to involve a whole team in order for this person to get holistic care. It's also important to offer psychoeducation if you are the therapist in this particular instance, so that this person may be able to understand how to cope, be able to understand how to manage stress, may be able to understand the cycle of violence, so that they can be able to do something about it. It's also important to go into the childhood history of this particular survivor to ensure that were there some unresolved issues that could be making this person to be able to withstand this kind of violence. Yeah, CBT is also another technique that is used. When it comes to children, you will do all that, but if the child is mute, you can apply other techniques of gathering history, like you can do play therapy, you can do art therapy, you can even do the house tree person kind of therapy, where the child will draw, you will use colors, and then if you're a psychologist, it means that you've been trained to be able to understand the meanings of different colors that this child is going to be using. So it will help you to know whether to actually make out what is happening with this particular child. The do's and don'ts: be sensitive. The world for many GBV survivors can be lonely, isolated, and filled with fear. So it's important to sometimes just reach out and let them know that I'm here for you. And this will provide a tremendous relief for them. Survivors sometimes feel misunderstood and unsupported during the interaction with mental health professionals. So it's important to take note of your words. What kind of words are you using with this person? If, for example, the GBV survivor was also diagnosed at some point with depression or another mental disorder, labeling the survivors with these psychiatric conditions may cause them to feel as though their abusive situation is not understood, and that you're focusing more on their disorder than what is actually happening to them. So this could lead to mistrust. And also when handling GBV survivors, always use a trauma-informed model to ensure a positive engagement with the patient. And this is the model. It's important to ensure that your client is safe, ensure that the environment is welcoming, it's private. The choice, ensure that your client has a choice to make. So it's important that you provide a clear and appropriate message about their rights and responsibilities. Collaborate with the survivor so that you don't make decisions for, but you make decisions with this particular individual. It's important to make this person to trust you. So task clarity, be consistent, and also observe interpersonal boundaries is important. Then it's important also to empower your patient or your client by prioritizing empowerment and also skill building. So provide an atmosphere that allows individuals to feel validated and affirmed with each and every contact that they make with the treatment facility that they have come to. These are some of the assessment tools that as a professional, you can be able to use to determine the level of risk. We have the danger assessment, which is a 20-item scoring instrument. It will help you to determine the level of danger of an abused person, of being killed by an intimate partner. We have also one that can be able to check for suicidality, like Beck's hopelessness scale and Beck's scale for suicide ideation. Your client could also be going through, you want to determine whether your client could be developing PTSD. So using a PTSD checklist is also very, very important. Survivors normally go through a lot of stigma, so sometimes you can also be able to use the self-stigma of mental illness scale to be able to assess the 3 phases of stigma, of self-stigma that this person could be going through. Maybe that is what is preventing this person from seeking help. Your history taking together with these assessment tools will inform your treatment plan that you're going to be able to draft for this particular survivor. Recommended psychotherapies for GBV include CBT, among others, eye movement desensitization processing, EMDR, and all these are evidence-based psychotherapeutic approaches that have been found to help people who have gone through abuse, because CBT will address not only the PTSD symptoms, but if this person is also self-medicating with substances, then this approach will work very, very well. Now, sometimes you will not only be approached by survivors for help. Sometimes even the perpetrator may come to you for help. So what do you do in this case? Will you call the police because this perpetrator or the instigator has brought himself or herself? Will you chase this person away? Maybe not. The most important thing is self-awareness. Ask yourself, what emotions is this perpetrator or this instigator evoking in me? And if this person is evoking negative emotions in me, then the best thing for me to do as a professional is to refer. I will not help this person because I will only harm them as opposed to helping them. So what will I do? I will refer this person to another professional, to my colleague. But if I choose to be able to help this person, what I'm going to do is to ensure just what I said: safety, listen, empathize, be genuine in my approach, take history when this person is comfortable, and of course develop a treatment plan that is a multidisciplinary approach. For the Kenyan team, these are some of the hotlines that you can be able to share with your clients so that they can be able to reach out and know that help is there for them. I want to conclude by saying that it's important to take care of yourself. Handling trauma cases day in, day out may take a toll on you emotionally and even physically. So it's important for you also to get help. Go for personal therapy, go for supervision, take part in other self-care activities so that, and as I quote Brian, taking care of yourself is the most powerful way to begin to take care of others. Thank you very much for listening to me. And I'd like to invite my co-presenter, Richard, to take us through the next session. Thank you.
Thank you very much, Jackie, for a wonderful presentation. I want to thank you for making it so clear. And, we know that GBV is intricately connected to substance use. And so as we move on to our next presentation, I will be sort of presenting what I have for you. And I would like to share my screen now. From that end, I'm not able to see the screen. Could I ask Jackie to share the screen? She has the presentation, so that I don't keep you waiting. As we wait for the sharing of the screen, I would like to say that GBV is intricately connected to substance use. And what we are doing tonight is we are exploring and looking at the increased risk factors that have come about because of substance use. We are also going to be looking at how the new approaches that we have begun developing in terms of dealing with substance use. So for this particular session, I'll make it quick because we have taken quite a bit of time in terms of the time that we have allocated. We shall be trying to understand the new risk factors for SUDs and also explore the professional new strategies that people are developing in this time and age to be able to develop new approaches to dealing with the substance use and also GBV. I want also to emphasize that GBV is not confined to one gender. We know that we have more men these seasons who have also been victims of GBV, and we have also women who have also been victims of GBV. Let's move to the next slide. So we are looking at the new risk factors, and we are looking at ways of developing new strategies. This is a conversation that we have begun on this platform so that we can be able to engage. Many of you who are on this platform are either practicing or are already engaged in substance use interventions and also in GBV. And so it's a conversation that we need to continue from here. And it is a conversation that will help us develop new strategies in managing both. Next slide, please. So substance use, we know, is includes a number of conditions that involve hazardous and harmful use of psychoactive substances. It can also be related to substance dependence arising from repeated or continuous use of the psychoactive substances. We do know that there are a range of psychoactive substances. Some are legal and others are illegal. We know that in our setting, in our country, we have alcohol, we have tobacco, we have mira or cat, which are basically legal. They are legislated, but they are available for sale. Then we have the illegal ones, which basically fall under the various groups of stimulants and also depressants and opiates, and some of them are heroin, cocaine, and so on and so forth. So depending on the type of psychoactive substance one is using, then the manifestation of the disease will follow that etiology of the particular drug that person is using. But remember that in the season of COVID, like Jackie has said, a lot of things have changed. Remember that people tend to look for coping mechanism in times of great distress, in times of great want, like now. And so the data that is being generated now will be able to inform the new protocols that we are going to be using in terms of dealing with substance use disorders and also basically dealing with the gender-based violence. Data from the World Drug Report of 2019, which is pre-COVID, shows that 271 million people worldwide aged between 15 and 64 years used an illegal drug once in the past year, while 35 million suffered with substance use disorders. And this is pre-COVID. Right now, there are studies that are ongoing to show what is currently happening. And I'm sure some of those figures we may change dramatically, but we shall see some of the reasons that can cause them to change either way, increase or even decrease. We also know that there are some ages that have not been covered, like people who are below 15 years. We know that there is also wide use of psychoactive substances, and so studies would be able to inform that too. Next. In our country, the studies that have been carried out recently been carried out by the national, the NAADAC, the National Authority for the Campaign Against Alcohol and Drug Abuse, and the prevalence of alcohol among adults 15 to 65 years have been indicated that over 12% of our population are current users. That is about 6 million people using alcohol, using and also probably abusing. In these times of COVID, these figures may change, and we'll see why. The use of cannabis, which is illegal, this one falls into the category of illicit drugs, is 1%. That works out to about 2 million people, or 2 to 3 million people. Then we have cat miraa, which is also a controversial drug because it is a legal stroke illegal drug in the sense that it is not legislated. And 4%, which is really quite a large number, you are talking about nearly 4 million people. And then prevalence of multi-drug use, those who are using more than one drug at the same time, 6%, which goes again to over 6 million people. Remember, Kenya has over 48 million people, and if you look at those figures, they are quite high. Next, please. The onset of the pandemic in March 2020, remember this is when we got our first cases here in Kenya, saw a very serious and dramatic effort by the government to be able to deal with the pandemic. And some of the things that Jackie mentioned are valid to gender-based violence as well as SUD. There was serious economic recession and unemployment. People lost jobs. People could not get new jobs. People who were already opening up new sort of jobs had to close them up. We see high levels of isolation because some people who are working in different, for example, in our country, different counties, could not move to another county. And if you had a family living in one county and you are working in the other, you sort of got isolated from your own family. And that in itself created other stressful factors that would probably result in drug use. Then there is the emotional and psychological distress that is associated with all this. I know many of you, like me, have felt the burden of having to be locked in, having to be controlled, having to wear masks, like have been said before, having to do things so differently. This causes emotional and psychological distress, and psychoactive substances really do come in terms of relieving the stresses and the emotional discomfort that caused by this by this condition. There is, of course, the increase in alcohol and other drug use. We shall see that, and also, of course, the increase in gender-based violence. Persons affected by substance use disorders are very high-risk populations for both SARS-CoV-2, which is COVID, and of course, COVID-related illnesses. And remember that these populations, like for example, the commercial sex workers, the people in the streets, street families, people who are truck drivers now cannot drive anymore. These are very vulnerable populations. Next. So there are quite a number of challenges and risk factors that are connected with this. We see very high levels of stress, fear, anxiety, idleness because no jobs to do, and when you have any job to do, you have to do it in the home, like we are all now, you know, getting to some normalcy, but again, we are still working from home. Boredom and uncertainty. Getting into confined spaces, like has been mentioned by Jackie, is a very unfamiliar territory for all of us. We are used to moving about. There are, especially in Africa, we are very hands-on people. We are emotive. We hug. We do all these things. this has really affected all the other aspects of our own lives. Forced relationships. What we mean by forced relationship is that you find yourself with people whom you would not normally live with. Fathers who are absent from their families because of work have been forced to be home. Mothers who are absent also are forced to be home. People who were not talking are now talking, and sometimes they don't have much to talk about because they didn't have a conversation before. So this has created in itself a very, very unfamiliar platform. Then there are complications arising from comorbidities, for example, personality disorders and even mental illness. And we also know that there is also reduced access to medications because of the worldwide lockdown, and of course also the sectional lockdowns within the counties, and this has also affected the way we manage substance use disorders. There is also a breakdown of psychosocial support systems and group support programs. For example, Alcoholics Anonymous, Narcotic Anonymous, faith-based support, where people were getting together in groups. This was disrupted and they could not be able to do that. Reduce access to treatment, and of course the curfew effect on the addiction professionals, which basically means that practitioners who did not have had a permit to move from one location to another found it very difficult to operate within the confines of the places that they normally operate in. And this is very important for especially addiction professionals, because as ISSUP, we were able to help some get sort of passes to be able to access treatment facilities and to be able to move from one locality to the other under the curfew effect. Next. We see among the professionals themselves that there was increased burnout and decreased self-care because they were not being able to access supervision. And it is in itself, there is burnout. There is the fear of even contracting COVID. And so this in itself was already a platform for stressful situations. New challenges in contextualizing evidence-based interventions. Jackie has mentioned about cognitive behavioral therapy, motivational interviewing. This involves a one-on-one person-to-person engagement. This was also disrupted because, again, wear masks, sanitize, keep distance. That all has, interrupted the normal, what we know, the normal evidence-based interventions. Difficulties in case management in view of physical distancing, isolation, and of course the quarantines and lockdowns we have talked about. Loss of specialized personnel, and this is because many of the healthcare professionals went to the effort of fighting COVID. They were taken away from their normal duties and they would go and be retrained to be able to now handle COVID patients. And this in itself drained the already exhausted field of having people who can deal with substance use disorders, people who can deal with GBV at the same time. Next. Issues of reduction, harm reduction services in terms of availability of, say, methadone for those who are in heroin treatment, syringe exchange, and so on. That was also disrupted. Complications of managing patients with both SUDs and COVID-19. Many people, even practitioners themselves, were fearful and are still fearful of contracting the virus because they are in scenarios where they have to constantly interact with people who are not necessarily free from COVID. Next. Now, marketing companies, both for illegal and legal psychoactive substances, also found new ways of reaching out to the communities because this was a platform in which they were not able to operate normally. Bars were closed, pubs were closed, clubs were closed, social gathering was not there, and so their market, schools were closed. And so they needed to look for new ways of reaching out to the consumers and recruiting new ones. And of course, if you see in this particular one, you can see liquor store delivery, and there are very many new liquor stores that have opened up that are selling wines and spirits on wholesale. If you look at every place, especially in our capital city, Nairobi, and I'm sure worldwide there are quite a number of these episodes where people are delivering maybe even marijuana and even these other psychoactive substances to people who are already in lockdown. And this has already now created another scenario where we may see a big leap of even new recruits, because once you are confined, you are very vulnerable and you may find yourself wanting to use the psychoactive substance. Next. Innovative strategies for substance use disorders and also GBV have led to rapid increase of effective web-based teleconsultation platforms. And this is one of them, where we are training online, or where you can converse online, offering new methods of engaging with persons with substance use disorder or even other disorders. And though this is not holistically as effective as our one-on-one scenario, this is a new platform, and internet has never been as important as this season. Telemedicine offering increased adherence to treatment by removal of logistical barriers associated with physical attendance at treatment services have also been offered. And so we know that the way forward, going forward, it will be very important to be savvy, techno-savvy, and using new applications to be able to reach out to those who are suffering from substance use disorders and who need help also in gender-based violence. Next. There are some considerations also to make, like, for example, the digital solutions have been hastily improvised, and people were very quick to look for new ways of doing things in a new way, and often lacked the support in the form of clinical guidelines for people with substance use disorders. Remember, we have treatment protocols that are available, but these were rendered sort of redundant in the new setting. So we had to look for new ways of doing things, but they were hastily done. And so going forward, it may mean revisiting these guidelines and saying, how then do we use telemedicine? How do we use the virtual platform to be able to incorporate treatment protocols that are relevant to our country, our people, and other continents? Some specific groups of people, especially those with physical cognitive comorbidities, who are not able to, for example, they don't have sight or they can't hear, or may not be reached by these digital solutions, increasing the risk of social exclusion through the digital divide. Next. So there is in a very important aspect and need to adapt and evaluate these hastily implemented approaches in the next phases of the pandemic. The pandemic is not over. We know that vaccinations are still going on. They don't provide full coverage, and yet we must continue operating as normal as possible. There is need to develop new plans for care of people who suffer from substance use disorder in this post-COVID era. And of course, we need to be retrained, many of us, to go into programs that will involve retraining and also revisiting curricula that would help us begin adapting to the new dispensation. Next. I'm nearly finished. Factors related to economic crisis which could lead to increases in substance use include reduced availability of psychoactive substances, higher prices, and financial restrictions. The first three may lead to a temporary decrease in the use of psychoactive substances. But the last one, emotional distress, isolation, and unemployment, may be a risk factor that may escalate that particular problem. Next. So what is the way forward? There are many things that we could do, and there are many things that people are doing. Healthcare and social care systems need to prepare to cope with a likely increase in demand in other domains of health, mental health, housing, access to medications and other fundamental goods, and what has been mentioned by Jackie, social stigma and self-stigma, and the systemic competition for economic resources between substance use disorders and other disorders. We often see priority being given to other areas of healthcare. Mental health is excluded in most times, and also substance use disorders. but we need now to relook at this particular field with eyes that will help us to be able to deal with it equally as we deal with the other issues regarding health. Next. So this is basically some of the thoughts that we may want to share. Greater use of outpatient treatment was COVID-19 to improving quality of care. Here we could establish a hybrid integrated addiction care model. This model could span from early detection, brief interventions in primary care, both health and social, and of course, highly specialized treatment and rehabilitation services in the new era, in the new platform. Next. So what is the role of mental health practitioners in management of SUDs? There are many, but some of them include, these are the people who first offer treatment to patients with SUDs and other comorbidities. Mental health practitioners are well placed to diagnose underlying SUDs in patients who present with mental health issues. Symptoms of mental issues often overlap or can be confused with those of substance use. And now we do not know how COVID-19 will also influence this symptomatic bias or symptomatic problem where you cannot tell what is what. Persons diagnosed with mental health problems often turn to substance use as a coping mechanism. These persons with SUDs often suffer from mental health problems. So mental health practitioners are a critical component of the clinical multidisciplinary team for SUDs. Next. So lastly, we need to remember that in these times, in these seasons, the COVID-19 pandemic offers a unique opportunity to update, reshape addiction treatment and gender-based management systems and networks through improved integrated access to care facilitated where appropriate by technology. The national helpline for substance use disorders is 1192, the NAADAC helpline. You have also the other helplines you have been given for gender-based violence, and I believe these presentations will be available to you. So I want to thank you for listening and enduring the time. We have gone a little over time. If there are any questions, we'll be able to answer them. And also we have people on the platform who can also be able to help us to answer any other questions. The next one, of course, is references that you can look at in terms of your reading further. Thank you very much, and you have a good, what is called African Day. Today is AU Day. 25th of May is when the African Union was formed, the Organization of African Unity in 1963. So we need to congratulate the people of Africa and the efforts they are doing in terms of dealing with gender-based violence and also substance use disorders. Thank you very much. Over to Dr. Pamela Kirote Kaithuri.
Thank you, Dr. Gakunju. Thank you, Jackie, for that great presentation. You have helped us to gain a lot of insight as professionals. You realize that there's a lot of work for us to do. The two presenters have unraveled for us how intricate the issues of gender-based violence are and substance use disorders, and more so the complication also that arises, or the new situation that arises because of COVID. And I really appreciate the fact that we have been attentive. We have a few questions, about 10 questions, some of which have been responded to. And I really appreciate the fact that all the participants have been very attentive. One question that Jackie can respond to at this time. Jackie, there is a question on what is ITP therapy. Kindly, if you can respond to that. Also, there is one participant who is asking, actually saying that the children issues are very delicate, and often GBV is occurring even at the family level. How can we be able to help the children as professionals? Kindly respond to those two questions first.
Right. Thank you very much, Dr. Pamela, and thank you for the questions to the participants who have asked them. Interpersonal psychotherapy, basically IPT, has been shown to be an effective non-exposure based treatment, particularly for PTSD. So it is evidence-based and it has shown to work very well with persons who have been diagnosed with PTSD. It requires someone to be trained on it for you to be able to offer it effectively. Number two, about children, it's important to recognize the symptoms that are presented by children because, as I mentioned, some children may not know how to verbalize some of the things that they are going through. So it's important to be able to notice or to be able to use certain techniques to be able to bring out what could be happening to these children. As I said, art therapy, play therapy, or you can even use the house tree person, which has been shown to be very effective, especially particularly when they start using certain colors and you can be able to interpret the meanings of those colors, or they do drawings and you can be able to see that this child has drawn a person with a big mouth, for example, with big teeth, and sometimes you could see that this child has drawn with the genitalia exposed. So that can tell you that there is something about this big mouth, the big teeth, something that is out of the norm with the normal shape of a person. So you can be able to gather a lot of information through that. A child who is bedwetting. So basically it's just a matter of identifying the symptoms of what could be happening to the child, but be very, very patient. Sometimes this child may not even draw for you, may not even speak to you for days. So it's important to be very, very patient in order to be able to get information from this child, but make sure this child is comfortable and feels safe with you. Thank you.
And thank you, Jackie, for responding to that question. Someone is asking if we'll be able to provide these presentations. Yes, this is a recorded session and it will be shared. So be keen to get the record. Again, a lot of commendation, a great presentation. Again, I think I need to say thank you to the team for the great presentation. It's highly appreciated by those who have been able to attend. I don't see a question on substance use disorders. I'm sure it's been well understood, so I presume. And then I would want to Jackie to respond also to this question, or basically make a comment that the abuser often seems to apologize, even for the injuries they inflict on the people. Why this tendency?
It's basically because of that cycle. Remember, even the perpetrator may not understand that they're actually going through that cycle of abuse, where it starts with tension, explosive phase, reconciliation, and then the honeymoon phase. So the perpetrator may not even be aware they're going through that phase. So it's basically a way of them trying to right the wrong that they have done. When you apologize, either in words or with gifts, it's a way of showing that you're actually sorry. And sometimes the perpetrator, this is how the perpetrator was brought up. And it may be a way of also him asking for help. He or she needs help to stop this cycle. But unless they understand the cycle, they will not stop. That's why it's important as part of your treatment to be able to psychoeducate on the cycle of violence, because somebody cannot solve a problem if they don't know what the problem is. Thank you.
Great, Jackie. What is really notable is the importance of awareness creating in the community, so that then even the abusers and the person abusing, the people with the substance use disorders can be informed, the community can be well informed, so that then they can be able to reach out to the professionals for support. And as it is emerging that the work out there is cut for us as professionals across the country. There is evidence-based interventions that have been presented to us, and many more that we can really learn on our own and be able to intervene, because the society, the community, our nations really need us. I realize that we have our time so much overspent, and I know this is a very rich topic that we looked at. We really tried to compress it. I hope that we can be able to, maybe with concurrence of the chapter, go deeper into this topic maybe another time, so that then we unravel it better and better for the professionals to understand, for us also to be able to interact and even share experiences, so that we can learn from the other community of substance use prevention professionals and better our practice and our profession. I want to say thank you once again to all the participants. And 33 countries that registered, and well over 300 participation. Again, I want to say thank you so very much. Your time is highly appreciated, and I hope you understand that the time that you have overspent, really, it was because we started a little late, and we hope that next time we will be able to keep time and be able to have a better opportunity to learn. I allow Dr. Gakunju to close this session for us. Dr.
Thank you very much, our moderator, and thank you for giving us opportunity to just explore and discuss some of the new dimensions of approaching gender-based violence, and also looking at substance use disorders in a new way, in a new mode. And I know that the participants are keen to engage more with this. We are also keen to engage more. This also provides us an opportunity to begin looking at opportunities that are there, especially in regard to research. What has actually happened will really inform us on what will happen going forward. So for me, is to thank all the participants, and to thank the moderator, also Pamela, to thank Jackie for a wonderful. GBV is actually a key pillar in this country, and a lot of people are looking forward, I think, to more sessions on gender-based violence for both male and female, and of course, including the children. I also want to thank Albert, who has been very useful in terms of managing the platform, and also our president, Evans Olo, who has been following keenly on what ISSUP Kenya is doing. And we want to thank the global chapter of ISSUP. We know that they have given us a lot of support, and going forward, we are going to see more and more of other international players coming into this platform to be able to share with us the other fora where they are doing the work. So thank you very much. The Lord bless you. The Lord keep you. The Lord be gracious to you. Thank you.